So this video is all about osteochondral allograft. We're going to talk about what is an osteochondral allograft, who is it indicated for, how you perform the surgery, and lastly, I'm going to review a series of cases that I've done in years past to just illustrate what kind of impact you could have in a patient's life with this surgery. So first, what is an osteochondral allograft? Well, this is a type of transplant surgery, and it's designed for people who have a missing piece of cartilage, generally in their knee, although it can be used in other joints. And when you do this, what you're doing is you're transplanting a piece of bone and cartilage from somebody who's passed away and transplanting it into that joint to replace the defective area of cartilage. So osteo stands for bone, chondral stands for cartilage, so bone and cartilage, and allograft stands for the source of the graft is from somebody else, not from your own body and not from an animal. It's another human being who unfortunately has passed away. So here you're going to be able to see just a picture of the most common form of osteochondral allograft, which is a couple of cylinders. And you can see here, you've got the cartilage on the end of the cylinder, and then here is the bone. And generally this is going to be anywhere from 7 to 10 millimeters. Here's just a smaller version of the same thing. Now, why do an osteochondral allograft? What's different about this? Well, what's different is that this cartilage right here, this is real and normal cartilage. So we do have a lot of different ways to try to treat patients who have missing cartilage in their knee or other joints. But most of those, in fact, I would say all of them, except for this, all of them create some type of cartilage or some type of transplant that is not completely normal in its architecture. So what's critical is to understand how complex cartilage really is. It's not just this homogeneous soup of cells and collagen. It's got order to it and detail, and depending on the depth that you look at, it varies. Look at these two slides here I'm going to show you. So this is a slide of hyaline cartilage. This is the type of cartilage that covers the ends of your knees, so your femur and your tibia, or in your hip or your shoulder. Any joint for the most part is going to use hyaline cartilage. And you can see here all these little cells. But as you get more superficial, the cells get smaller and less dense, and there are almost no cells up in this layer. This is the articulating layer right here, and down here is the bone. You can see just by looking at this cross section, there is a huge difference depending on where you are in the depth of this cartilage. The architecture, the detail is very different. So here's a diagram representation of cartilage. Look at the different zones. You've got the deep zone, the transitional zone, the superficial zone, and each of these represents an area of cartilage that's distinct and different from the other ones. We talked about the cellular density and makeup already. We can also talk about the fibers. You see the fibers, they're talking about the collagen fibers and their orientation relative to the bone. And so in the deep zone, the collagen fibers are perpendicular to the bone, which is down here. In the transitional zone, they're kind of randomly oriented. And at the superficial zone, right where you would see that glistening, smooth cartilage, they're parallel. Now here's the point. When we do other techniques such as microfracture or Carticel, or take other types of allograft cells to try to regenerate cartilage, we're not getting this level of architecture. We're just not. We're trying to get close to it, and sometimes you can. Many cases, what you get is you get fibrocartilage, which is completely different, and it's not the same in terms of its biomechanical properties. It doesn't last as long, it doesn't have the same amount of cushioning and resilience. This is a complex structure, and you only get this structure if you transplant it from somebody else. At least so far, that's our only real option. So that's why you do osteochondral allografts, and that's what an osteochondral allograft is. It is a sample of bone from somebody else, a bone and cartilage from somebody else, and that cartilage is perfect. It's normal, unlike any other thing that we can do to try to treat a cartilage lesion. So who is an osteochondral allograft for? When would you indicate this type of procedure? Well, there's a few things that I look for. I look for younger patients, teens, 20s, 30s, and maybe young 40s, but generally the younger patients. You're looking for an isolated lesion. So the whole knee is not arthritic. You have one small area that maybe you had a traumatic event and you knocked off a piece of cartilage. So that's a good candidate. You want to make sure that the patient doesn't have any significant meniscus or ligamentous deficiencies. So an example of that would be somebody who's already had their meniscus removed. If you've taken out that meniscus, you've lost some of the biomechanical property of that meniscus, and now the cartilage there is exposed to excess force, and that's a problem. And if you don't correct that and you put in a transplant, then it's going to fail. We also look to make sure that your mechanical alignment is good, and I'm going to talk about that in a second. And we shouldn't generally see kissing lesions. That means you should only see a lesion, as I said, pretty isolated, and you can't have it on both sides. So not on the femur and the tibia where they're hitting each other. That's a problem, right? You really just want it on one surface and in an area that you can generally address. Now, I will say this, not all parts of the knee are equally accessible to osteochondral allografts. For instance, one of the hardest places to do this with is the trochlear groove. That's the V-shaped groove where the kneecap runs in. The anatomy is so variable patient to patient that's difficult to transplant effectively without having high spots or ridges. And so we don't do it as often in that instance, but it can be done. So how do we perform these surgeries? Well, first, we obviously have tried all conservative management to get somebody better. Oftentimes you've done therapy, injections, you've tried braces, you may have had a prior microfracture or a failed Carticel procedure, and now we're left with osteochondral allograft as our last resort. Or sometimes we'll jump straight to that if the lesion is so big that nothing else will work, because there are size parameters that work better for osteochondral allograft than other types of cartilage restoration procedures. And so what we'll do first is we will size your knee via the MRI, get the idea of how big a graft we need, and also what are the dimensions of your knee. See, everybody's different, right? And so your knee is different too in terms of its size, in terms of its width, in terms of its height. And there's going to be a patient that fits you better who's donated their knee for this cause who dies. And we're going to have to wait until that becomes available. So you're on a waiting list, and basically you've committed to be ready to do the surgery when that graft becomes available. So what happens is we get a call, and that could be weeks or it could be months, or I've even seen it take over a year, depending on the graft. We get a call, and then we say, hey, we've got a graft for you, Dr. Hurt. It fits your patient. Please look at these pictures and the parameters, and they give me some information on it. And as long as I feel like it's acceptable, then I will call the patient and I'll say, okay, we've got the graft. Are you ready to do the surgery? We have to put this in within 4 weeks because that cartilage is not going to stay alive forever. This is important. The cartilage that we transplant is living. All right. And what's amazing about it is you don't have to get a match, meaning you don't have to match your body's genotype to theirs, because there's not really a big rejection risk with this. Osteochondral allograft is amazing because it is immunoprivileged. What that term means is that your immune system can't access that cartilage because there are no blood vessels in cartilage. You know, this is one of the downsides, is that it doesn't repair itself well. But one of the plus sides is we don't have to match you perfectly genotypically because the immune system of the patient won't, as I said, access that cartilage. The way that that cartilage gets nutrients is through the synovial fluid, not through the blood. So that's incredible, right? And so we don't even look at that part. We don't have to do all that testing, and we don't have to do any type of immunosuppression. You can sometimes see some absorption of the bone on the backside. I've never seen it, but it can happen, and you can get a sinkhole phenomenon. And the answer is you can just go put a different one back in and usually resolve that issue. But regardless, getting back to the procedure, what we would do is we would call you and say, are you ready to do this? Because they're testing it right now. For 2 or 3 weeks, they're testing it to make sure there's no diseases or anything that are going to be transmissible. And then you're going to have about a week's window between days 20 and day 30, somewhere around there, to implant this, because it expires after a period of time, because too much time will have gone on and the cells inside that cartilage will have died. So I give them a call, I say, I like this graft, and the patient says, great, I'm going to cancel my schedule, let's do the surgery. And so we put you on the schedule, and then they send the graft to us. So that's the first part. Then we'll actually do the surgery itself, where we go in, we take out a piece of cartilage from your body, and then that's deficient, and we put in the new cartilage. Let me show you a little diagram of what that looks like. All right, so you can see here that we've got a cartilage lesion in the bottom left, and It's just showing that it's arthritic right there where the X is, all right? And so what we're going to do is we're going to remove that cartilage and a cylinder of bone that goes with it. And as you can see, normally this is 5 to 9 millimeters deep, somewhere around there. And then we will take the corresponding allograft that we will have obtained from the donor, and we will put it in to replace it. And what we're trying to do is get this as smooth as possible at these transitions so that we can run our fingers over that and not feel any bumps. And that's the essence of the surgery. Typically, we'll keep you non-weight bearing for somewhere like 4 to 6 weeks, and we'll get your knee moving right away. These knees, allografts don't actually hurt that bad. I mean, there's the part, if we do other parts of surgery, which we're going to discuss in a second, that can hurt, but the actual osteochondral allograft, it's a pretty quick recovery. And at 6 weeks, there's enough time for that bone to really fuse to your bone that we can get more aggressive and walk on it. Because that bone cylinder is not yours though, and it has to repopulate with cells, because there are cells that go to that bone and repopulate it. We need to limit your athletic endeavors for a period of time. I would say at least 6 months, and some people will go up to a year. We don't want to pound on that while it's still healing, all right? Other than that, it's just get your knee moving and slowly rehab your muscles and your strength and your flexibility. Now, I told you that we do have to correct sometimes pre-existing conditions to make it possible to do this. So if you're missing a meniscus, sometimes you might have to do a transplant. One of the most common things that I do and that you'll find associated with osteochondral allografts is an osteotomy. Now, osteotomy is a term for cutting the bone. And what we're doing is we're cutting the bone, either the femur or the tibia, and we're creating a wedge to change how the weight is passing through the knee. Because many times a patient is either knock-kneed or bow-legged. And if that happens, these patients are putting too much weight through this area where they're having a cartilage lesion. In fact, sometimes that can be the thing that caused it in the first place. And if you do not correct that, if you do not correct that imbalance, that poorly aligned knee, then your graft is doomed to fail. And this is really important. So I use this analogy. If you buy a plant from Home Depot and you plant it in the shade and it dies, and then you take it back and you say this plant died, and you get another one, you plant it in the shade and it dies, and keep doing that again and again, and you forget to look at the information and realize it's a sun-loving plant, it needs to be in the sun, you're going to keep wasting your time, right? You have to improve the environment for that plant to be able to survive. You have to put it in the proper place. Same thing applies with cartilage. If you do not improve the overall environment so that it has the chance to thrive and exist and continue to endure for many years, then it's going to fail. So that's hard to really wrap your arms around, and it's hard to face the fact that you have to add sometimes a pretty major surgery. So let me review 2 of the most common ways that we perform osteotomies to offload the knee. They're called high tibial osteotomies and distal femoral osteotomy. So here's an example of a distal femoral osteotomy. The bone is cut almost all the way across, probably 9/10 of the way. It's wedged open, and then an extra piece of bone is put in there to fill in the gap. And then you put a plate along the side and screws to temporarily reinforce it while it's healing. And what that's doing is that's taking the weight from this side and pushing it over to this side. Another example is a high tibial osteotomy. Same concept. You cut the bone almost all the way across. You put a wedge in here of bone. You put a plate here that's got screws here. And what that's doing is it's taking the weight from this side and pushing it to this side. And obviously the idea would be to offload any cartilage allograft that you put on the side that you're trying to move the weight away from. These are big surgeries, and not as many surgeons perform these with frequency or high numbers, and so you just want to make sure that whoever's doing this for you has a lot of experience or training in how to do these. But they do great, and these can make a huge difference in the long-term survival of your graft, and it should be considered anytime you do this. You should get a long leg weight-bearing x-ray before you do this, and if that's not being done, that's a sign of concern. So the last thing I want to do is I just want to review a PowerPoint patients that I've done this surgery for in the past. And so we'll have pictures from the surgery. So if you're queasy, you may not want to watch this. And we will review their symptoms from before surgery. We'll go through the actual pictures from the surgery, as I said, and then we'll look at their x-rays years later and also just go through what they experienced in very simple form, how they saw results or didn't see results, etc. And hopefully this helps you, because I feel like anecdote is one of the best ways to communicate a concept. It doesn't mean that these patients are going to be representative of everybody, but it's a good sampling. And lastly, we'll look briefly at how these survive over time just by reviewing one study that looked at that. Okay, so this is the first case. This is a medial femoral condyle allograft that was done after somebody had failed Carticell. That's a different type of procedure done to try to regrow cartilage from your own cells. And so he was 38 years old, and he'd had 7 months where his pain was getting worse and worse, and he couldn't even straighten his knee, he couldn't mow the lawn, and he had a bad limp. So you can see a couple little metal anchors here. Here's where surgery was done, and all of his pain is here on this side. I got an MRI, and here's what you can see, is you can see that this patient's cartilage lesion and their bone defect is much worse than that x-ray suggested. So somebody could look at your x-ray and say, I don't know why you're hurting. And until they get this MRI, they're not going to know exactly how bad the issue is. X-rays, they just don't always tell the whole story. So what you're seeing here is you can see cartilage right there, then there's a gap between those two. This is bruising of the bone. It's responding to the fact that there's a hole there. All this is bruising. And again, you can see a huge crater between here to here. You can imagine that hurts. So the first thing I did is I got long leg weight-bearing x-rays, as I discussed. So these measurements are not important. What's important is that we go from the center of the femoral head to the center of the ankle, and I can see that in both the right and the left knees, this patient is going through the medial femoral condyle. This is actually pretty typical, and the problem with this is most of their weight is going through the area of concern, and so we need to offload this in addition to doing our allograft. So I get a call. Joint Restoration Foundation is a wonderful company, physician owned, and they do a great job with providing these allografts in terms of their sources and how they run their business. So you'll get pictures. This is the same graft. This is looking from the end on over here, and this is looking from the front. And you've got measurements, so you can see here, and you can compare that to your patient measurements and make sure that you like the relative fit. You can see the age of the patient and when this patient passed away, unfortunately. Remember, we have a time period that we have to get this in before it expires. So if I accepted that, and then the patient was able to do it, so back in November 2014, we did a 22 millimeter wide osteochondral allograft, and we did a 9 millimeter bone wedge. That was that osteotomy that we discussed. We did a high tibial osteotomy. And so here is the before. You can see this massive cartilage defect, and that's corresponding to that MRI. And then this is afterwards, exact same, but look how pristine that looks. It's the only thing that will get you that level of normalcy. You can't get it looking like that with anything else, in my opinion. And of course, we know that, as I discussed, you can't get the histology, that cellular architecture recreated with anything other than transplanting it. So that was in 2014. Now this is 2016. He's got full range of motion, no limp. He says if he's really active on it, it aches a little bit for a week. He's not taking any meds, and he tried jogging, and he could do that with no pain. I love it when people are honest. I said, would you do it again? He said, definitely, but I would not have said that right after surgery. This is not an easy surgery to just fly through. This takes a big commitment, and you're going to continue to improve for at least a year. That's just the truth. On the x-ray, you can see here the osteotomy that's already healed. This is a couple years old, and they've got good joint space here. All right, elongated medial femoral condyle allograft, case number 3. So this patient is 22 years old. This was back in 2015, and for 2 months his knee was getting worse. Somebody else had done drilling in California. That probably was microfracture, and it had failed. And this guy's trying to be active. He wants to be in the police academy, okay? And so he couldn't even complete a senior year of golf, which is, golf, just walking 18 holes. because he couldn't walk down the fairway. So that is the level of pain that we're dealing with. He's failed conservative management. X-rays, you can see something right here. Looks a little abnormal, and right here. I did the long leg weight bearing X-rays again, and then he had this pretty big lesion. So in this case, we did a 30 by 12 millimeter oblong graft, filling in this big gap. And here it is after the graft is put in. We also did a 10 millimeter bone wedge for a high tibial osteotomy. And so here he is now, over a year later. You can see where the osteotomy was done. The bone is healing in. You can see it, if you look close, you can see that allograft right there. And in terms of his response, he's actually doing great. He could sprint. He was mainly biking and rowing. Obviously he could walk, he could golf now. And he was in the modified police academy, and his range of motion had improved. So he was really happy. And I've actually seen this patient back even years after 2016, and he's still doing great. So this case is really interesting. Bilateral. So 17-year-old young man unfortunately had some condition in his life that caused both of his knees on the right and the left to have these cratering cartilaginous and bony defects, and it was killing him. 2 years of bad pain. He was taking anti-inflammatories all the time. He couldn't play soccer or run without having pretty bad swelling and pain. Here's the profile views. Again, it should be continuing all the way around like this, but instead you see a crater here and here. So this is what it looked like in real life back in 2012. We had to do a larger incision because it's harder to get to the lateral femoral condyle, so we cut the patella insertion point and moved it over here, and so that's what's underneath gauze. And here's the defect. You can just see it's missing. That should be all white cartilage, all right? And so this was harder because I had to do some freehand cutting. So we created now the recipient bed, and then I go to the back table and I have the allograft set up on a special stand that holds it in place for me. And then you can see here, I'm cutting with a saw, coming across here, and then I'll come back here, and it's by hand. So there's just some workmanship here. And you can see afterwards what I had left after I'd done the cuts. I provisionally pinned it in place with these K wires just to hold it in place. And then I pinned it permanently there. And then we did the other knee, 2013. This is how it was all beat up. This is after I prepped it. Now I've placed it in place, and there's 3 screws holding this new allograft in place. And here's the end result. 2013, you can see it right here. You can see the screws over here. You can see a little bit of the graft over there. These screws were from that osteotomy of the tibiotubercle that I did so I could get exposure. And how did he do? He did great. So back in 2017, when we called him, he had no daily pain. He was avoiding impact activity, but he was biking and swimming all the time. He actually had played indoor soccer with only mild pain. And here are the x-rays. You can see one little piece of bone broke off back there, but otherwise his graft incorporated really nicely all the way over here. Okay, osteochondral allograft for the patella. Super rare. I've only done one of these, I think, and I don't want to do a lot of them because they're difficult to recover from, but when necessary, it's really a life-saving procedure. So this gentleman was 27 years old. He'd been dislocating his kneecap since childhood, and when you dislocate your kneecap, you hurt the cartilage on the backside of the kneecap, and that's what happened with him. So he had had a prior surgery to try to stop that. His other knee had already had a Fulkerson, and it had done well, but that was years before. And now he's getting really bad pain. It's swelling. He can't even bike and run, and he's frustrated. So here's some cross sections of the MRI, and you can see here where this arrow is, he's missing cartilage, and there's even bruising right here in the bone. These are just multiple cross sections. So I look at the profile view, and indeed, where these 3 arrows are, he's supposed to have cartilage, and he's just missing it. You can see the normal cartilage on the back side of the femur, all the way here and here. So back in 2014, we did an osteotomy to be able to facilitate getting this, and so you can see that right here, the cut tibiotubercle, and we flipped that kneecap backwards so we can see the kneecap, and right here, this is all bone, exposed bone. So we did an allograft MPFL reconstruction, which is where we stop it from dislocating with a new ligament. Fulkerson osteotomy, where we do this osteotomy right here and offload the kneecap. I won't talk about that right now because it's beyond the scope of this talk. And then we did an osteochondral allograft of a kneecap. We transplanted the back of a kneecap. So 3.5 years after surgery, how did he do? Well, you can see here these screws, and you can kind of make out the graft right there. And then the cartilage, which you can't see, is back here, right? And see, again, this was from the osteotomy, the fulcrum that we did. He said it was really hard, almost 1.5 years until he could say, I'm better than I was. But now he could go for a 50-mile bike ride only with mild discomfort. Remember, he couldn't bike before this, and he wasn't taking any anti-inflammatories, and stairs, going up and down stairs, which put a lot of force through the kneecap. That was normal for him. So that was a really big surgery, rare surgery, and he did really well. Obviously, had no dislocations. Last case. This is articular surface humeral head allograft. So really sweet and unfortunate 13-year-old girl who's been a long-term patient of mine. And she had avascular necrosis secondary to chemotherapy. Avascular necrosis means avascular, lack of blood supply, necrosis, death. So she'd had ALL and had to get chemo, and one of the side effects of chemo can be bone loss, or in this case AVN, and that's what happened. So we see these x-rays right here and right here. Normally this ball should be nice and smooth and all the way around, and it looks like a deflated beach ball. You can see here a 3-dimensional CT scan that shows that deflated beach ball, and then one of the cross sections you can see this surface is supposed to be all the way out, articulating with the socket right here. So we get a call for the graft. 34-year-old unfortunate person who passed away, another woman, probably because that would make the size small enough for her. And you can see here different views. And in surgery back in 2017, we have the graft here, and then we have the resected humeral surface, So I cut the surface off and put it right next to it to show how beat up this was. And then we sized it with this sizer. And then we have the actual graft, and I put a little pin in it so I could use it to manipulate and hold it in place. And here it is implanted with 4 screws, and here it is after surgery. So you can see now you've got a much more normal contour. Compare that to this original x-ray here. Here she is taking her arm through a range of motion. I actually ended up doing her right and her left shoulder. This is many years after both of them were done, and she just did amazing. Such an amazing patient, went through so much. She's also had other surgeries on her hip, and we've done stuff on her knee. I'm so proud of her. So this is just a graphic representation of the survival rate for osteochondral allografts. You can see that this was done in 2014, and basically they just looked at how long, for these 58 patients with this age range, how long those grafts survived until they had to take them out, all right? And so on this y-axis, you can see survival rate. And on the x-axis, you can see timeline. And all we're looking at is how many grafts are still surviving as time goes on. So at 10 years, roughly 85%. We're still surviving. 20 years after the surgery, 60%. And 30 years after the surgery, 55%. These are incredibly durable when done correctly, because remember, the cartilage is living, and when you correct the alignment, you can change people's lives. So while science is increasing all the time, osteochondral allografts are still one of the best things we have for focal areas of cartilage loss in younger patients. This is not for osteoarthritis or rheumatoid arthritis patients, all right? This is for usually traumatic or sometimes idiopathic focal cartilage loss. So hopefully this whirlwind tour of osteochondral allografts was a help to you. I love this procedure. When indicated correctly, it can change somebody's lives. Thanks for watching.